continuous vaccine to the pregnant ladies, because in some parts of the world, some parts of our country also, this diphtheria disease has been diagnosed in the children. Okay, otherwise during my internship, during my MBBS time, during my house officer time, being working as a house officer, I've never seen any cases with diphtheria. Okay, so anterior, so there are major clinical types which child presents with these three clinical types, which are anterior nasal diphtheria, facial type diphtheria, and laryngeal type diphtheria. So it affects basically the where the bacteria infects the human being, like if, whether it is an anterior nasal, whether it is facial region, or whether it is a laryngeal region. Okay, and other sites that could be affected by this bacteria is skin, conjunctiva, even the eye, gastrointestinal system, and genital area. But these are very rare areas. Okay, and most commonly it affects anterior nasal part, facial part, and laryngeal area. And how it affects this Corynebacterium diphtheria, it's toxic strains of Corynebacterium diphtheria. So it produces a very powerful exotoxin, which is responsible for the formation of grayish or yellowish membrane over the tonsils. And these grayish or yellowish membranes are known as false membrane. It looks like a membrane, but it's not true membrane. It's a false membrane produced by this exotoxins produced by Corynebacterium diphtheria. Okay, and it is produced over the tonsils, pharynx or larynx, with well-defined edges. The edges are very well-defined, okay, and smooth, regular, and the membrane cannot be wiped away easily. Okay, it's a very permanent type of membrane. You can't easily scrape it off. Okay, and it causes marked congestion, edema, or local tissue destruction. Besides producing this false membrane, it also causes congestion, redness, inflammation, edema, or local tissue destruction. Okay, surrounding the affected area. And there will be enlargement of the regional lymph nodes, submandibular lymph nodes, anterior neck lymph nodes are enlarged because of this bacteria, inflammation caused by this bacteria. And the person will show signs and symptoms of toxemia. So if you see this oral cavity picture diagram, then this is called hard palate, this is upper lip, this is lower lip, and if you open the mouth, this is hard palate followed by soft palate. After soft palate, there lies the facial pillar, posterior facial pillar, and the anterior facial pillar. Okay, and below that lies the this is uvula, and this is tonsils, palatine tonsils. These are the tonsils. These are the facial regions. So if it affects the facial area, it is known as facial type, and okay, according the affected area, they are termed accordingly. These are the tonsils, and this is pharyngeal wall, and inside the pharynx there is larynx, and beneath the larynx there is trachea. Okay, like that. So you know the causative agent. So it is Corynebacterium diphtheria. It is gram-positive bacilli, non-motile, it cannot move, which produces powerful exotoxin. And this diphtheria bacilli are sensitive to penicillin, group of drugs, and are killed by heat and chemical agents, and differentiated into four types. So there's a Corynebacterium diphtheria. They have divided into four types: gravis, metis, belfanti, and intermedius. And what is the source of infection? We human beings are the source of infection, and we again in human being also, it could be case or carrier. So case means person who gets active infection and who develops signs and symptoms. So some person get infected with the bacteria and produces signs and symptoms. So those are clinical cases. And some diseases remain asymptomatic without producing any significant, developing any significant signs and symptoms. So they are known as subclinical type. And carrier state. So in carriers means people they harbor, but they are asymptomatic at all, but they have a capacity to transmit the infection to others. So they are the carriers. Okay, so carriers are the most common source of infection as compared to cases, and carrier could be temporary or chronic. For certain time being, they carry the bacteria, and then you know the person will be bacteria free after a certain time. Chronic, for long periods of time, the person will harbor the bacteria and will keep spreading the infection by transmitting the bacteria through naropharyngeal secretion while coughing, sneezing, okay, and by other modes of infection. And nasal source of infection, nasal and throat carriers, they are the most dangerous source of infection. So if they harbor this bacteria in their nose and or in their throat, then while coughing, sneezing through nasopharyngeal secretions, they can transmit the disease. And immunization does not prevent the carrier state. Now here, what you have to understand is you can prevent the disease in cases, okay, but if the person is in carrier state, immunization does not work. So infective materials, what are the infective materials? So what are the materials that you have to which can if you handle without precaution, you can acquire the disease. So nasopharyngeal secretions, okay, sputum, secretions from the nose, okay, discharges from the skin lesions if there is wound in the skin, if the diphtheria has affected the skin, the person develops cutaneous lesions, okay, wounds in the skin. So those discharges erupted from the skin lesions. Contaminated fomites. Fomites means objects used by the diseased person, like cups, linens, clothes, bed sheets, utensils, okay, buckets. Beside water and food, water and foods are not called fomites, but other objects which the patient uses and which is contaminated by their secretions are known as fomites. So if you touch those clothings, beddings, blankets, clothes used by the diseased person, and if you don't you wash your hand properly, and if you through that hand you touch your nose, then mouth, then you will be infected too. And through infected dust, if sometimes after sneezing, immediately after sneezing, or if you spit out the sputum, the bacteria may survive in the environment or in the dust for certain time period. So if you inhale those dust, then you can get infected. So those are the infective materials. So just like in COVID-19 also, similarly here in diphtheria also, same thing, nasopharyngeal secretions and all. And period of infectivity, 14 to 28 days from the onset of disease. Okay, so disease has been started. Now after up to from that day up to 14 days to 28 days, the person can transmit the disease to other healthy person, but carriers may remain infective for much longer time. So 14 to 28 days is for the cases who develops frank signs and symptoms. Okay, what are the signs and symptoms I'll be discussing um, in my next slide. So but carriers who will not show any signs and symptoms, they may remain infected for much longer time, for months also, okay, weeks, months. And the case or carrier may be considered non-communicable when at least two cultures from nose and throat should be taken 24 hours apart. One sample should be taken from the nose and sent it for culture, and after 24 hours, another sample from throat should be collected and sent for culture again. And if these two cultures reports comes out to be negative for diphtheria bacilli, then the person is considered as disease free, and the person is now disease free and will not transmit any diseases. This is how we confirm. Okay, like in COVID-19, we repeat the PCR test, polymerase chain reaction. Here we do the secretions culture. So host factors. Who are the hosts? Who are the people who whether people who are affected by this disease, then there are children. There's mostly it affects children between age to 5 years. So after 5 years, the disease prevalence is very low. So that's why we have to be more careful while dealing with under 5 children, because under 5 children they are vulnerable for various communicable diseases. That's why we vaccinate them. So after 5 years, okay, we don't vaccinate the child, if the child is not vaccinated before, and if they present to you after 5 years old, when they have become 5 years old, then we don't give vaccination. But if they have survived that much, then what happens? They have already developed immunity against those communicable diseases. So it's of no point. So under 5 children, they are mostly affected with this diphtheria. So children age 1 to 5 years, and both male and females are affected equally. So while talking about the immunity status, infants born to immune mothers are relatively immune during the first few weeks or months of life. So if the mothers are immune, you know, immune, or she has been vaccinated when she was infant herself, then such infants born to such mothers are relatively immune. They will not, if they are exposed to the Corynebacterium diphtheria also, they will not develop the acute infection. Okay, that means, and during the first few weeks or months of life, because the antibodies, the body retained the antibodies they received from their mothers. Okay, the antibodies passed from their mother to the babies will remain up to 6 months to 1 year in the newborn's body. So it helps to fight against this bacteria. That's how they become immune. And environmental factors, so like this diphtheria disease, it occurs in all the seasons. However, winter months favor is spread. Okay, in winter, most of the children they get infected. Mode of transmission is obviously droplet infection. While sneezing, while coughing, if you don't cover your mouth, if you don't cover your mouth with your with handkerchief or with your elbow, what happens? That will through the air, it will what happens? The person standing nearby you who is in close contact with you will inhale the same air, and the bacteria will be inhaled too. Okay, and so infected cutaneous lesions would be the another mode of transmission. If through the cutaneous lesions, the discharge will be produced, and if the discharge is caused by another person, and if the person do not maintain personal hygiene, then from there also the disease can be transmitted, and can be transmitted by objects contaminated by patients' nasopharyngeal secretions. So while drinking, while using spoons, while sleeping, our nasopharyngeal secretion, saliva, sputum may, get spill over. Okay, and then if the same objects are used by the other healthy person, then through our nasopharyngeal pharyngeal secretions, it will get transferred to other healthy persons. So that's why, if any person is diseased, whether a mild common cold to TB or Corynebacterium or COVID-19, we have to make sure that all the contaminated objects used by patients are thoroughly clean, thoroughly disinfected. Okay, and we wash our hands and we use masks while encountering such patients. So the portal of entry from where it enters our body through respiratory route is the commonest route, through our nasal airways. While inhaling, it enters and it reaches our lungs and reaches our system. Okay, and non-respiratory routes are skin. So, in the cutaneous type, if there is wound, and if you have cuts and wounds and through or ulcer, then if it's not attended, it's not cleaned by Dettol or other saplings or betadine, it's not covered properly. What happens from those cuts and wounds and ulcers? Okay, the bacteria might enter into our body. So the cuts in the healthy person, if left unattended, then those bacteria might enter through that also, and through umbilicus also in your newborn. Okay, that's why they apply. It is hexidine these days. Hexidine and this antiseptic. They apply 4% hexidine around the umbilical area once the umbilical is caught. Okay, it is disconnected from the mother, and through eye, genitalia, or middle ear. But this is very, very occasional route. And incubation period. So incubation period, that from the time the bacteria enters our body to the time we develop any signs and symptoms, that is called incubation period, and it is 2 to 6 days. In COVID-19, they are saying 14 days, but now up to 21 days, um, they are touting that the incubation period is up to 21 days, because after 21 days also people are developing COVID-19 disease. So that is incubation period. And for this, for diphtheria, it is 2 to 6 days. And talking about the clinical feature, how the diphtheria affected person, children will present to you. Okay, so it can in respiratory tract forms if the bacteria has entered through the respiratory pathway, then it might the children might present with one of these forms. These are uh, different types, different forms of diphtheria: laryngotonsillar diphtheria, laryngotracheal diphtheria, nasal diphtheria, or it could be combination of these, pharyngotonsillar or laryngotracheal, both, or pharyngotonsillar plus nasal. It could be like that. Okay, so in pharyngotonsillar diphtheria, the child will develop sore throat, घाटी खसखस हुने, दुख्ने, just like in tonsillitis, and the child will have difficulty in swallowing food, and the child will also develop low grade fever. Low grade fever भनेको 99, 100, 101 सम्म मात्रै हुन्छ, not more than that, है. 100, 103, 104 भनेको चाहिँ high grade fever. Then on examination of throat, when you ask the child to open the mouth, okay, then you will see erythema, mild erythema. Erythema भनेको redness of the mucous membrane. Okay, uh, during pharyngitis and tonsillitis, if you ask your friend to open his or her mouth, then you will see that the pharyngeal wall, tonsil, all congested, red, erythema. That is erythema, and because of the the dilatation of the superficial capillaries. Okay, so that part will look red, localized exudate, or a pseudomembrane. So there could be there will be, you'll see mild erythema, congestion, localized exudate, little pus may be there. Okay, or a pseudomembrane could be there. You can see the pseudomembrane also. And in the early stage, the pseudomembrane may be whitish and may wipe off easily. So in the early stage, when the pseudomembrane has started forming, then it will be of white in color, and you can easily wipe it off with the help of tongue depressor, or for fork, let's say a tongue depressor. Okay, ENTs will be using tongue depressors, and it may extend to become things. So slowly, what happens in later stages, this pseudomembrane will become very thick, and it will change in color also. From whitish, they will turn to blue white to grayish black. Okay, and now they become adherent. They will adhere to the mucous membrane strongly. Now you can't wipe it off easily. You have to, if you try to scrape it off, it will start bleeding because it will be adherent to the mucous membrane. So exotoxin causes necrosis of the epithelial cells and liberates serous and fibrinous material which forms a grayish white pseudomembrane. So how this pseudomembrane is formed? This exotoxin produced by the diphtheria, Corynebacterium diphtheria, it causes necrosis. Necrosis भनेको death of the cells of organ or tissues. Okay, so it causes death of the cells, of the epithelial cells, um, of the mucous membrane which is inside the oral cavity, and liberates serous and fibrinous materials. Now this serous and fibrinous materials forms a grayish white pseudomembrane, and this is how it looks. You see it partly that this is the pseudomembrane at the early stage, okay, in the posterior pharynx. Now when it becomes very large, the it will obstruct the airway. Now this person will start develop having difficulty in breathing as well. Okay, so in severe cases there will be, along with this pseudomembrane and along with this um, difficulty in swallowing and fever and sore throat. And what happens if the child is just left untreated? Okay, if treatment is not given, now the child will develop marked edema. Edema means swelling of the mandibular area and the anterior portion of the neck, and lymphadenopathy. There will be enlargement of the lymph nodes of the neck area also, and this will lead to bull-necked appearance. Bull-necked appearance. Bull-को neck जस्तो हुन्छ अरे, because it becomes very large and swollen. Okay, as it the swelling submandibular area and anterior portion of the neck will be swollen up, and the lymph nodes in the neck, anterior regions, and submandibular lymph nodes will all be swollen up. Okay, and it will give the bull neck appearance. So this is a child with severe diphtheria. Now in severe diphtheria, what happens? The child has a conjunctivitis also, and there is pharyngeal membrane is also affected, erythema is there, and bull neck is there, and even myocarditis. He has developed myocarditis. It has affected the heart also. And in such condition, all vaccines are contraindicated. This is in the severe cases, but severe cases not so common. Okay. The next type is laryngotracheal diphtheria. Laryngotracheal, as name suggests, it affects the larynx and the trachea of a child. So pharyngotonsil up to tonsils, it affects pharynx, and tonsils are affected. Here it will go further down, and most often preceded by pharyngotonsil. So if you develop inflammation of the larynx and trachea, so it will not be possible until and unless it affects the nose and pharynx. First it has to affect the nose and pharynx, then tonsils, then it will move down to pharynx and trachea. So here also most often preceded by pharyngotonsillar disease. First a child develops pharyngotonsillar diphtheria, then slowly the child will develop laryngotracheal diphtheria as well, and the child will develop fever along with that. As uh, you must have noticed during common cold also, your voice will change after. If you develop severe common cold and cough, then your voice will change. That is because you are having laryngitis, inflammation of the larynx. So similarly here, as it affects larynx and trachea, now the child will develop hoarseness voice. The voice will become hoarse. It will become very thick and blunt type, and the child will have a croupy cough. The cough is known as croupy. That is very harsh cough, harsh and high pitched cough will develop. Okay, and followed by prostration and dyspnea. So what happens? The child will develop this croupy cough, very a strong cough, which is like forcefully the child will start coughing out. So after coughing, what will happen? The child will feel extremely weak, prostration, fatigue. Okay, with the malevolent fever, and if you have bouts of cough, then what will happen after that bouts of cough stops? You will feel very tired, and dyspnea. The child will also develop difficulty in breathing after the croupy cough, and sometimes the child may also feel suffocated. The child may feel suffocation. So, in severe cases, the child may have to be intubated or tracheostomy. Okay, suffocation can be felt if the child is not intubated or tracheostomy is not done. So, in severe cases, what happens is there will be difficulty in breathing. As I showed you, the pseudomembrane will obstruct the airway. Now, in such cases, if you don't intubate one you have to uh, there's a tube which in a tracheal tube which the anesthesiologist there's this insert inside the larynx up to the trachea so that the child airway will be patent. Okay, so if not done, then tracheostomy, there's a hole you make in the middle of the neck so that it will help the child to breathe through that hole, the hole that the doctor makes in the neck. Okay, that is tracheostomy. And if it's not done, the child may suffocate and eventually may die also. So toxin produced within the membrane is absorbed, causing distant toxic damage. So this toxin produced by this Corynebacterium diphtheria will be absorbed in the surrounding areas, okay, and will lead to parenchymatous degeneration, fatty infiltration, and necrosis in heart muscle, liver muscles, kidneys, and adrenals. That's why this child is having myocarditis, inflammation of the heart muscles, because now in severe cases toxin, what does it do? It starts affecting the distant organs as well and cause fatty infiltration in the liver, you know parenchymatous degeneration and necrosis, death of the cells in the heart muscle, liver, and kidneys, and adrenal glands. So later there may be difficulties with vision, speech, swallowing, and movements with the arms and neck. So gradually, if the child is untreated, okay, and or treated very late, then the child will develop difficulties in vision. There will be difficulty in speaking, also swallowing, also, or while moving arms and legs, also, and also nerve damages leading to paralysis of soft palate, eye muscles, or extremities. So this diphtheria is laryngomalacia diphtheria is quite serious as compared to pharyngotonsillar diphtheria because it can lead to paralysis of soft palate, our eye muscles, or even a paralysis of our extremity, that is hands and legs. The next one is nasal diphtheria. Nasal diphtheria and cutaneous diphtheria, they are not so, serious. Okay, it doesn't lead to serious conditions. So the nasal diphtheria is mildest form, and it is localized to the septum or turbinus of one side of the nose. So I think you know what is septum or turbinus. Septum is the bone inside the knee, no, or nose, which divides the nose into, in between the two holes there is a what is that called? There's a like it's a thin bone lying between the two holes. Okay, and turbinates are the long narrow passages inside the nose beside the septum, which actually helps to moisten or cool the air which passes into the nose through the in through this terminus from the nose. So when the air passes from the surrounding into the nose, it is very dry. Okay, so inside this, when it travels through the terminus, it gets moistened. Okay, and you will not feel dryness of the nose. But when you put on the heater, then what happens inside the nose also? It becomes. It can't function well, and you'll feel very dry nose. That's because so this terminus makes sure that the air is environmental air is moistened. So so it just affects the septum or turbinus of one side of the nose only. So it's very very mildest form. And cutaneous, so person will develop mild common cold like features, or fever. Okay, and nothing more than that. So cutaneous diphtheria. Cutaneous means when they affect the skin. So it is especially this occurs in tropical areas, in countries where the climate is hot and humid, like Argentina, Chile, Sahara Desert, where the climate is very very hot and humid, and often appears as a secondary infection of a previous skin abrasion infection. So cutaneous diphtheria can also appear as a secondary infection of a previous. So if there is skin abrasion or infection, if a child has skin infection of some due to some bacteria, now what happens? This bacteria can again infect the child through this skin wounds. Okay, a secondary infection, primary होइन secondary, कुनै अर्को ब्याक्टेरियाले कज गरिरहेको अब फेरि यसले पनि गएर कज गर्न चाहिँ secondary infection भन्छ. So now how to diagnose the immunity status of a child, whether the child is immune to the diphtheria or not, or whether they need to be immunized or not. It is called check test. It's written SCHICK, but C they don't pronounce it. They pronounce it as SHIK, Shik test, right? Shik test. So it is intradermal test, which is done to find out the susceptibility or immunity of the child, whether the child is susceptible to the bacteria, or whether they are immune to the bacteria, bacteria which causes diphtheria, and also to find out hypersensitivity of the child for diphtheria toxin, like whether he will have develop any adverse effects after giving the vaccine or not. For that, we have to do the shit test. Okay, so how it is done? First, you give zero point 0.2 ml of diluted toxin. So this diphtheria toxin is diluted, and zero point 0.2 ml is injected intradermally in the left forearm, and it is a test arm. Now, here you have injected the toxin, so it's a test arm, and the same dose of detoxified toxin which is detoxified. So once you detoxify it, it doesn't have this toxic effect. Okay, and zero point 0.2 ml of detoxified toxin is injected in another, that is right forearm, and it is considered as control arm. Okay, and you need this you would inject the detoxified toxin so as to compare the results with the test arm. and that's why this is known as control arm. So how to interpret this result? So if positive reaction, when there is development of erythema, there is redness of skin of more than 10 millimeter diameter within 24 to 48 hours. So after injecting 0.2 ml of toxin, after 24 to 48 hours, the child will develop erythema. If you measure the diameter of that erythema with a scale or measuring tape, it will be more than 10 millimeter, and it reaches its maximum size on fourth or fifth day. Okay, it increases further in diameter on fourth and fifth day, and fades away by seventh day in the test arm, and no such changes will occur in the control arm. So if this kind of erythema is developed in the test arm within 24 to 48 hours, and which increases in size on fourth and fifth day, and on seventh day it starts to fade away, then that case is positive. That positive means child is susceptible and requires immunization. Child can acquire diphtheria disease, so the child is vulnerable. Now you have to give the immunization. Negative means there is no development of erythema in both arms. Means the child is immune and the child doesn't require immunization. But here we don't do shit test. Okay, we just vaccinate all the infants as per the government's rule. So how to control diphtheria? So there are cases and carriers. I told you. Cases means people with obvious signs and symptoms. Carriers, they harbor the bacteria, but they are asymptomatic. Okay, so first of all, you have to detect the cases. Early detection plays a vital role in controlling any diseases. I know. If you detect any disease, at late stage, then you can't do much. So early detection is very, very important. For that, an active search among family and school contacts should be done, and carriers detected by nasal and throat swab culture. So if there is active, you have to go house to house. You have to do house to house survey, and you have to find the active cases. Okay, and then carriers, so you can't find out the carriers. You have to take their nasal or throat sample, and you have to send it for culture. Those swabs, which through with the help of swab, you have to collect the nasopharyngeal secretions, and you have to put it in a specific test tube, and you just send it for culture. That's how you do early detection. Second one is after detection of active cases, you have to isolate them. It's just like in COVID-19. Once the patient is PCR positive, you have to put that patient in the isolation ward for 14 days. I know it's not only 14 days in diphtheria also. Not only cases but suspected cases in त्यो विदेशबाट आएकोहरूलाई क्वारेन्टिनमा राखेको के हो we are suspected cases are being kept in home quarantine also. Quarantine mindfulness is a bit different. Quarantine means the person is exposed to the infection, so the movement is limited. Okay, so as to limit the contact with the diseased person. That is quarantine. That is what is done in the COVID-19 suspected cases. Isolation means the diseased person is kept in a room, okay, preferably in the hospital or at home, and that person is kept in a certain place, so as that person will not, um, the healthy person will not be exposed to the diseased person, and disease will not be transmitted. So the slightest difference is quarantine healthy people so as to prevent from getting exposed. Isolation diseased person to prevent exposure to the other healthy person. Okay, so here in diphtheria, all cases, and even if the person is suspected case, I mean, could be that person could be, suffering from that suspected case, and carriers also they should be isolated. They should be kept in one place, preferably in hospital, at least for 14 days or until proved free of infection. at least two consecutive nose and throat swabs taken 24 hours apart should be negative before terminating isolation. So if there's cases, we have to give it for 14 days. But suspected cases in carriers, we have to do the test as soon as possible. And two cultures from the nose and throat, and collected 24 hours apart. And if they come to be negative, then you can send the person to their home for the cases and carriers. But for cases, you have to wait till 14 days and you have to do the test. So treatment for cases the who has developed signs and symptoms, you have to give the diphtheria antitoxin. Okay, and and because toxin has produced those signs and symptoms, so you have to give the antitoxin. How much? 20,000 to 1 lakh units or more, intramuscularly or intravenously. Along with the antitoxin injection, you have to give penicillin or erythromycin for 5 to 6 days. For carriers, after doing the swab test, if they come out to be positive, we have to give erythromycin tablet for 10 days. No antitoxin should be given to carriers. For contacts, now there is active case in the family. Now other family members, they are the contacts. Now their throat swab should be collected and their immunity status should be determined by doing sheep test. Okay, and if they have taken the primary immunization, okay, during their childhood, or booster dose was received within the previous 2 years. See, booster dose are given in the Western countries. In Nepal, we don't give booster dose for the diphtheria. We just give primary immunization. But in Western countries and India, they give booster dose. And if this primary immunization has been given, I mean, which is the case in our country, and if booster dose has was received within the previous 2 years, okay, then you don't have to do anything. You don't have to worry about it. Even if the throat swab comes out to be positive in then you don't have to do anything. So where primary immunization and booster dose was received more than 2 years before, then you have to give the booster dose of diphtheria toxoid vaccine. Booster dose, one single dose should be given immediately. If non-immunized close contact, if the siblings of the child, sister, brother of the child is not immunized, if there's someone in the family who is not immunized, okay, for the past 2 years, or not did not have not been immunized at all, then they should be given prophylactic penicillin or erythromycin. Then 1,000 to 2,000 units of diphtheria antitoxin also should be given, and then they should be actively immunized with diphtheria toxin. So diphtheria toxin immunization should be given, active immunization, antitoxin should also be given, and penicillin and erythromycin should also be given to non-immunized close contact. This is how you have to deal with the contacts. Now, bacteriological surveillance of close contacts should be continued for several weeks by repeated swabbing at approximately weekly intervals. So these contacts you have to keep on monitoring. Okay, you have to keep on collecting their swabs and doing tests. Okay, sending it for the culture for weekly at weekly intervals. Okay, that should be done. How how many times they have to repeat it? For several weeks, they have said. Okay, for several weeks, 3 4 weeks. So for community, how to control the diphtheria in the community? By active immunization with diphtheria toxoid of all infants as per expanded program on immunization schedule. So national immunization program and expanded program on immunization. Don't get confused with that. Okay, this is national immunization program, but it was expanded later on. It was vaccines for more communicable diseases against many communicable diseases were added in that schedule. That's why it's known as expanded program on immunization with booster doses every 10 years thereafter. So for community, you have to give the active immunization with the diphtheria vaccine. Okay, and diphtheria immunization, how it is available in the market. So it comes in the combined or mixed vaccines form like DPT, diphtheria, pertussis, tetanus vaccine. Now, in the park, it is not mentioned, but it is available in the market as pentavalent. Please note down pentavalent, pentavalent, pentavalent vaccine. So this pentavalent vaccine, it consists of this DPT, diphtheria, pertussis, tetanus. Along with that, it also contains hepatitis B vaccine, and Haemophilus influenza type B, capital H, small I, small b. Okay, Haemophilus influenza type B. There are type A and type B. So we in pentavalent we include Haemophilus influenza type B vaccine, hepatitis B vaccine, and DPT vaccine. So five vaccines are combined in one vial. This is done to for the patient compliance, so that in one injection shot, the child will be immunized against five communicable diseases. Okay, so it's not given in the book. It is not given in the like in this form like DPT, DTPW. DTPW means diphtheria tetanus, and small w stands for whole cell pertussis vaccine. And DTPA, diphtheria tetanus, small a stands for acellular pertussis. So there are different types of pertussis that is included, like your whole cell pertussis and how it is formed, how it is added. Your acellular pertussis vaccine is added to diphtheria and tetanus. And last two are only DT. So pertussis vaccine, once the child reaches 5 years old, there's no point of giving pertussis vaccine because the child will not develop pertussis disease after that. Okay, so if a child of 5 years old comes to you and you have to give the vaccine against diphtheria and tetanus, you give DG vaccine either. And the lower one, small d and capital T, is the adult type vaccine. So for pregnant women, if I don't know whether you know it or know it or not, pregnant ladies we give. I told in the beginning of my class also. These days we give this TT vaccine. Okay, diphtheria and tetanus. And in single doses also, single forms also, they are available in the market, but we don't use it, like FT, formal toxoid, alum precipitated toxoid, purified toxoid aluminum phosphate, purified toxoid aluminum hydroxide, toxoid antitoxin flocculus. So these are available in the market, but we don't give it because we believe in patient compliance. And antisera can also be given. Diphtheria antitoxin also can be given, I mean available. Okay, that's why we give it. So in combined vaccines, DPT. So if you are listening to me, it's given in the book DPT. That's why it is. I have written it here like this. But while in exam, you can write pentavalent directly. Okay, so in Nepal it is given as pentavalent, and it contains so and so vaccines. So the route of administration is same. Okay, so there are two types of DPT vaccines. One is plain and adsorbed, and we prefer the adsorbed one. So adsorbed means there's a slight difference between absorbed and adsorbed. Absorbed means you add liquid or solid in you add some substance in a liquid or solid, and it will be absorbed in that liquid or solid. But adsorbed means you just apply certain substance, you know, surrounding its surface, I mean around its surface, and that is absorption. Okay, and here DPT vaccine, outside that while manufacturing that vaccine, that around its molecules, that aluminum phosphate is attached to it, or aluminum hydroxide is attached to it. Okay, now why it is done? To increase the immunological effectiveness of the vaccine. When you apply this aluminum phosphate surrounding the DPT vaccine, now what happens? The immunological effectiveness will be increased. It will be more effective. Okay, immunologically it will produce a good more, I mean the antibodies will be produced um, adequately, properly, let's say. And storage, so this DPT, DT, all the vaccines should be stored in 2 to 8 degrees Celsius. All the vaccines at the immunization center will be stored at this temperature. Okay, 2 to 8 degrees Celsius, plus 2 to plus 8 degrees Celsius. So it will not be frozen. So frozen vaccines will be, I mean all the vaccines will be frozen at the manufacturing level only. Okay, once it reaches the immunization center, then now you have to store it between 2 to 8 degrees Celsius. And optimum age is 6 weeks. So 3 doses of TPT vaccine or pentavalent vaccines are given to infants at the age of 6 weeks, 10 weeks, and 14 weeks. Okay, first dose is given at 6 weeks, is 1.5 month, and after 1 month, that is at 10 months, the second dose is given, which is 2.5 months, and Next dose is 3.5 month. That is 1 month apart. Each doses are given 1 month apart. 6 weeks, 10 weeks, 14 weeks, or 1.5 month, 2.5 month, and 3.5 month. Okay, that's how it is given in Nepal also and worldwide also. And um, so it's going to be three. Okay, I'm about to finish. Arey, I haven't started the. What's the cheater time go as a? Remember your last class, eh? I think this is your last class. I will finish today only. Okay. So, hello.
Yes, ma'am.
हुन्छ है एकछिनमा म 15 मिनटमा सकाइदिन्छु है धेरै छैन पर्टोसिस पनि एक्सप्लेन गर्दा गर्दा टाइम गएछ सो कहाँ भयो ओके एन्ड इन्टरभल बिट्विन भइहाल्यो 1 month apart त्यसपछि बुस्टर डोज इज नट गिभन इन नेपाल बट इन वेस्टर्न कन्ट्रिज बुस्टर डोज एट 1.5 year to 2 years it is given and again after 5 years DT booster dose is given because after 5 years pertussis vaccine is not given so DT only given so two booster doses are given in western countries but for Nepal only the primary immunization primary doses are given and pertussis is added to this GPT because this pertussis component enhances the potency of diphtheria toxoid so diphtheria toxoid's potency you know will be enhanced, will be increased by pertussis components. That's why they are combined. उसले झन् उसको डिप्थेरियाको एक्सनलाई चाहिँ स्ट्रङ बनाइदिन्छ सो how it is given deep intramuscular in lateral aspect of thigh है यो तिमीहरूको पछि यो भ्याक्सिनेसनमा एकदम इम्पोर्टेन्ट छ इट विल बी it is frequently asked during viva and during internship also you have to do an internship in community medicine OPD where you have to sit for the immunization OPD and there you have to remember all this. So deep intramuscular and lateral aspect of thigh is given and reactions. So every vaccines, they once given, they will develop mild, minor side effects like fever and local reactions, mild local reactions. Local reaction, redness, swelling, there's up amounts of fever and mild swelling, redness, tenderness at the injection site. These are the minor side effects. And severe complications. Some infants may develop severe complications due to pertussis, like neurological disorders. Right? This pertussis vaccine is very, very notorious as compared to diphtheria and tetanus. This pertussis component, if the child, that's why this pertussis vaccine can lead to neurological complications that's why when the child comes to you for this vaccination you have to ask for the history of neurological disorder in the child right if the child is having neurological disorder like seizure disorder encephalopathy encephalitis convulsions then you can't give the pertussis you have to remove that pertussis component and you have to just give the DT in pentavalent you remove the pertussis component okay so neurological disorder भनेको encephalitis encephalopathy where there is a brain damage occurs and the child may develop seizure and then the child may have altered sensorium the child may be disoriented to time place and person in severe cases the child has a seizure or become unconscious may go into coma okay as encephalopathy because the disease has affected the brain and prolonged convulsions infantile spasm means seizure in infants it's known as infantile spasms where the child have this के भन्छ यसलाई spasm of the hands and legs and the head will be bent forward okay in this infantile spasm and Ray's syndrome पनि हुन सक्छ Ray's syndrome भनेको it affects the liver so liver is damaged and then the person will have this liver damage and अर्को एउटा के हुन्छ भनेर भनेको थियो आई फरगट जस्ट गुगल हेर्दा यो रेस सिन्ड्रम भनेको चाहिँ किडनी र लिभर एफेक्ट गर्छ त्यो पनि हुनसक्छ अनि कन्ट्राइन्डिकेसन्स कस्तो पेसेन्टलाई चाहिँ नदिनु त डिपिटी भ्याक्सिन भन्दाखेरि इफ द चाइल्ड कम्स विथ कफ कोल्ड माइल्ड फिभर देन यु क्यान गिभ द भ्याक्सिन माइल्ड कफ कोल्ड एन्ड फिभर is not they are not the contraindications to any vaccination you have to keep this in your mind but if the child has high grade fever if the child is having diarrhea vomiting that child is very very much sick okay and the child may need hospitalization then you can't vaccinate the child. You have to cure the child first, then after the child becomes healthy, then only you can call back and give the vaccination. And it should not be repeated if a severe reaction occurred after previous dose. So as I told you, this DPT vaccine, pentavalent vaccine, is 3 doses of vaccines are given. So in first after taking first dose, if the child develops seizure, if the child develops collapse, shock like symptoms, faints, and keeps on crying, no, for a long period, like persistent screaming episodes, they start screaming or crying unnecessarily, or if they develop high grade fever that is above 40 degrees Celsius, or they start developing convulsions, seizure, or I don't know, and anaphylactic reactions. Anaphylactic reactions भनेको severe side effects. The child develops rashes, there will be swelling in the mouth, whole body edema can occur. Okay, the child may faint also. So if such um, side effects have appeared in the previous doses, then you can't give the second or third doses. Okay, you have to stop it. Okay, that's why you have to ask the question. So children above 5 years who have not received DPT, only 2 doses of TT vaccine is given 4 weeks apart, with a booster dose 6 months to 1 year later. So if the child above 5 years comes to you, okay, then you have to give only 2 doses of DT vaccine 1 month apart, with a booster dose 6 months to 1 year later. That's all. For children above 12 years and adults, you have to give the DT vaccine, okay, and 2 doses given at the interval of 4 to 6 weeks. Mostly here we give 4 weeks apart, and followed by a booster dose 6 to 12 months after the second dose. So here for pregnant women also we give 2 doses only. We don't give booster doses here in Nepal. Okay, and single vaccines are less frequently used. And anti-sera, diphtheria, antitoxin prepared in horse serum is the mainstay of passive prophylaxis. So passive prophylaxis भनेको चाहिँ if someone gets exposed to this bacteria while working in the lab, while collecting the sample, while dealing with the patient, then you can give this anti-sera. Anti-sera भनेको diphtheria antitoxin. Or you know, treatment आयो नि कन्ट्रोलमा, or you anti-sera दिएको है, that is prepared in horse serum. So, it's quite easy. If you have any question, you can ask me. So, whooping cough. Let's move on to whooping cough. This is again a very small chapter. It is also known as pertusis. Pertusis is also known as whooping cough because pertusis causes whooping cough, right? So, whooping cough, one goes, as the name suggests, the patient child develops very lengthy. It's like violent attack of cough. Once again, coughing fit भन्छ, ग्रुपी cough fit भनेको एकदम बेसरी लहरे खोकी नै हो क्या अरे पर्टुसिस भनेको हो, लहरे खोकी हो है, त्यो मैले सुनेको होला, मैले त पेसेन्ट देखेको छैन. Then it's an acute infectious disease usually of young children caused by Bordetella pertussis gram negative coccobacilli. अहिलेको चाहिँ gram positive, यो चाहिँ gram negative coccobacilli, and which is obligate erupts. Okay, erupts, obligate, lamb obligate shape mounts. Yeah. So the causative agent of whooping cough is Bordetella pertussis, and that's why its disease name is also pertussis. And it is characterized by an insidious onset with the mild fever and irritating cough gradually. So suruma, child develops mild fever and irritating cough, but slowly, gradually it becomes paroxysmal. Paroxysmal भनेको मैले अघि भने जस्तै violent attack, होइन, एकदम लहरे खोकी आउने एकैचोटि non-stop, that is paroxysmal cough with the characteristic whoop. That is whoop भनेको चाहिँ यो नाम दिएको छ, त्यो characteristic कस्तो त होइन, whooping cough को चाहिँ whoop cough भनेको कस्तो भने loud crowing inspiration. So what happens when a child cough continuously, when the child is having that bouts of episodes of that attack of coughing, then after that attack the lung will be deficient of oxygen. While coughing, have you ever noticed when you cough violently for 1 to 2 minutes, you will hardly get time to inhale the oxygen. So then what happens? There will be no oxygen inside the lung. So just after the cough, the child will breathe, inhale. एकदम sharp inhale लिन्छ, एकदम long के भन्छ त्यसलाई, while the child inhale in the air, now the child will develop this loud crowing sound, right? Kagli, crowing sound. And how does the crow makes the sound? The child makes the same sound while inhaling the air. So it is often associated with cyanosis and vomiting. So what happens after that bout of coughing, the child lung will be deficient of oxygen. Then the child will may appear bluish, okay, because of lack of oxygenated blood in the body. The child will be cyanosed, and child may vomit also, right? And this disease is also called 100-day cough, because Chinese started calling it 100-day cough because this cough may last for weeks or months. Even for 10 weeks the cough may persist, okay. That's why they have named it 100-day cough. So it is one of the most lethal diseases of the infants and young children who have not been immunized, especially with underlying malnutrition and other respiratory infections. तिमीलाई त्यो साउन्ड कस्तो हुन्छ भने लास्टमा सुनाउँछु है त्यो हुपिङ कफको. सो एपिडेमियोलोजिकल डिटर्मिनेन्ट्समा as in factors, so the cocobacilli are responsible for pertussis, Bordetella pertussis. Source of infection is man. Case of infection is a source of infection. The person who is actively infected is a source of infection. And in case of pertussis, there is no carrier state. Carrier state हुँदैन. जो actively signs and symptoms develop गर्छ, who develop signs and symptoms, they are capable of transmitting the infection. There is no chronic carrier state in this. And infective material here is also similar to diphtheria, nasopharyngeal and bronchial secretions, and objects contaminated by such discharges. Then infective period is, so there are three stages खासमा यसमा है. So infective period is catarrhal stage भनेको this initial stage हो यो चाहिँ, which extends from a week after exposure to about 3 weeks after the onset of the parasite stage. So this infective period is as soon as the child is exposed to the bacteria up to the 3 weeks after the onset of the paroxysmal stage, the child is infective. And the child can infectious disease to others. From the day the child is exposed to bacteria, then the child develops signs and symptoms. Now, once the child develops signs and symptoms, till 3 weeks after that, okay, the child will be infective. So, secondary attack rate is 90% in unimmunized household contacts. So, secondary attack rate भनेको चाहिँ those who are infected with the from the primary cases. Okay, the person who develop disease who get exposed to the primary cases. There are secondary and who so 90% of the unimmunized household contacts may develop pertussis. Okay, so contact tracing is very important. So all it's a disease of infants and preschool children. Infants भनेको is below 1 years old, okay, and preschool children, and the highest incidence is found below the age of 5 years, and infants below 6 months of age have the highest mortality. So here it's just the opposite. So in diphtheria, the first 2 months the child may be immune, okay, because they get immunity from their mothers. But in case of pertussis, the child infants below 6 months, they have the highest mortality. They may die because of pertussis. Okay, it's a very lethal disease, and more female babies are affected as compared to male. And when while talking about the immunity, recovery from whooping cough or adequate immunization is followed by immunity. So once the child get recovered from whooping cough or gets immunization, the child will the child will be immune against that disease, okay, later on. So infants are susceptible to infection from birth because maternal antibody doesn't appear to give them protection. So simple case, in diphtheria, maternal antibody is giving protection to them, but here in case of pertussis, maternal antibody does not protect the infants. The environmental factors. So this disease occurs throughout the year, but more cases occur during winter and spring months. And the risk of exposure is greater in low social classes living in overcrowded conditions. Okay, because they have low, nutrition, they are malnourished, and the environmental condition is not so good, okay. So their immunity state is also very poor, that's why. And mode of transmission is droplet infection and direct contact. And incubation period is 7 to 14 days. अघि डिप्थेरियामा 2 to 6 days थियो भने यसमा चाहिँ 7 to 14 days, and but not more than 3 weeks. See, incubation period is not more than 3 weeks. Okay, so clinical course, it occurs in 3 stages. So it produces local infection. Organism is not invasive. It multiplies on the surface epithelium of the respiratory tract, causing inflammation and necrosis of the mucosa, leading to secondary bacterial infection. So what happens is it's not invasive. It just affects the surface epithelium of the respiratory tract, okay, and it multiplies there, and it just causes a local infection. It doesn't cause a deep ulcers as such, okay. It just affects the surface epithelium of the respiratory tract and causes inflammation, and then slowly causes the death of the cells of the mucosa, leading to secondary bacterial infection. This is how it develops. So it occurs in three stages. First is catarrhal stage, which lasts for first 10 days. So it is insidious onset. There is lacrimination भनेको आँखाबाट आँसु आउँछ, watery eyes will be there, sneezing, coryza भनेको तिम्रो sputum के अरे nasal discharge develop गर्ने होइन, तिम्रो respiratory tract infection भएर चाहिँ nasal discharge हुन्छ, and then there will be difficult cough. It occurs at night, but slowly the child starts coughing at daytime also. Then the paroxysmal stage starts where it lasts for 2 to 4 weeks. It becomes very rapid, consecutive uncontrollable violent coughs will develop, followed by a deep high pitched inspiration. After the violent cough, the child will have deep inspiration and it will produce a certain sound which is known as a whoop sound or kurpi cough, and usually followed by vomiting. So may causes cyanosis and apnea in young infancy. Apnea means there's a break in the breathing, okay? The child will not, there's a pause in the breathing, pause. So after violent cough, the child may turn into bluish color discoloration and may pause breathing for few minutes, okay. That is in paroxysm stage. This is a child having paroxysm cough. So the convalescent stage means the recovery stage where it lasts for 1 to 2 weeks, and the illness generally, while passing through the catarrhal and paroxysmal and convalescent, it usually lasts for 6 to 8 weeks. Okay, but in some children, the cough may occur till 10 weeks or more. That's why it is called 100 days cough. The complications. So pertussis have many complications. If not treated, then what happens, especially in infants less than 6 months, bronchitis, inflammation of the bronchi, bronchopneumonia, bronchiectasis. So don't think that what are these symptoms, diseases. Okay, these are the diseases of the lungs, okay, which will be taught to you gradually. So just remember that bronchitis, all the bronchi will be affected. So it will cause inflammation of bronchi, pneumonia, and bronchiectasis. Bronchiectasis, this is permanent, permanent disruption of the terminal bronchioles. That is bronchiectasis. The terminal bronchioles will be collapsed permanently. Okay, that is bronchiectasis. And violent paroxysm may precipitate subconjunctival hemorrhage. So when the child is having this violent attack of cough, the child may develop subconjunctival hemorrhage also. There may be bleeding in the subconjunctiva also. Epistaxis, bleeding from the nose. Hemoptysis means vomiting. Um, Hemoptysis means cough stained with blood. Okay, and punctured cerebral hemorrhages which may cause convulsion coma. So it may affect the brain also, where the cerebral hemorrhage may occur and may cause convulsions and coma. So that's why this disease is very lethal. The infant's mortality is high because during this violent paroxysm, the child may develop all these hemorrhages from nose, from eyes to brain. Brain hemorrhage may also occur, and the child may develop convulsions, coma, and may eventually die. Okay, so see, when the child is having non-stop cough, it gets very difficult to get air. Okay, so how to control? So the for cases, you have to diagnose it early. So after diagnosing, you have to isolate them, and you have to treat the cases, and you have to disinfect all the discharges from nose and throat. Okay, like by washing, by proper disposal of the pharyngeal secretions, nasal secretions, and washing hands properly, washing clothes, and everything should be done. And early diagnosis by bacteriological examination of nose and throat secretions obtained by nasopharyngeal swab. So, how to diagnose? You have to take the swab from the nose and pharynx, and you have to send it for the culture, and and from the throat, pharyngeal swab, that is from the throat, And fluorescent antibody technique test helps in rapid diagnosis of pertussis. That can also be done. Fluorescent antibody test. And then you have to give erythromycin is a drug of choice. Okay, it is given in for 10 days. So if the child is allergic to erythromycin or if erythromycin is not available, you can give ampicillin or tetracycline 2. So these are the alternative drugs. Now, what about the contacts? If a child is suffering from pertussis, all the family members, siblings, they are the contacts. So they have to be infants and young children. If there are other infants and young children in the house, they should be kept away from the cases. Those who have been in contact may be given prophylaxis. So mothers who are taking care of the babies who are suffering from pertussis should be given prophylactic antibody for antibiotic for 10 days. Sorry. So the best protection that can be given to so this erythromycin can be given for 10 days, okay, as a prophylaxis. Prophylaxis means before developing in signs and symptoms, you are giving the antibiotics so that the person will not develop any signs and symptoms. And the best protection is for if the child has siblings, then to give vaccination to his or her siblings before another baby is born. The first child should be vaccinated as soon as she is born. I mean during infants. So active immunization is the best method to prevent this disease again. So DPT, the same thing, 3 doses, 6 weeks, 10 weeks, and 14 weeks, 0.5 ml, given deep intramuscularly at lateral aspect of thigh. And the adverse effects are so local reaction at the site of injection, mild fever, irritability. So this is you can write in any vaccination topic, you can write that local reaction will be there. Okay, there will be some kind of redness, tenderness, swelling at the injection site, and the child will develop fever. And the rare reaction that pertussis can develop are persistent, inconsolable screaming. Sometimes mothers come complaining after vaccination, my child is just screaming and just crying non-stop. And I tried many things, but I couldn't make her stop crying and screaming. So it could be the side effect of the vaccine. Seizure. Some child may develop seizure. Some child may develop anaphylactic reactions, and very rarely encephalopathy can be developed. And contraindications when if the child has any kind of anaphylactic reactions, if the child gives any history of anaphylactic reactions in the past, you shouldn't give it. If the child is having encephalopathy, you can't give it. If the person or the strong person or strong family history of epilepsy, if the child's mother, father, or the child itself is having epilepsy, convulsive disorder, you can't give it. Convulsive CNS disorders, um, any febrile upset until fully recovered, or reaction to one of the previously given triple vaccine injections. So any reaction side effect to the previously given this DPT vaccine. If there's anything which this, if the child has any of these, mm, the history or reactions, then you can't give the vaccine. Okay, so passive immunization is hyperimmunoglobulin is yet to be. So passive immunization is there against pertussis, but stop its effectiveness is not that so much established. Okay, it's not proven though, so we don't give it. So now I'll show you the YouTube. Please don't leave the classes how the whooping cough sounds like.
Husband got it on video. A nurse practitioner saw it and diagnosed it right away.
And she saw it. She goes, "That's pertussis."
Whooping cough is also bacteria.
Diagnosed it right away.
And she saw it. She goes, "That's pertussis."
A nurse practitioner saw it at a coughing fit. Her husband got it on video. A nurse practitioner saw it and diagnosed it right away.
Okay, that's it. Cough, cough, cough.